Welcome, ladies and gentlemen. I'm Dr. Silva. Thank you for joining me for this talk on Orexin receptor antagonists. I just did a video on the insomnia armamentarium where I talk about the various medications, the classes of medications that are in use for the treatment of insomnia, primary and secondary insomnia. And as a coda to that, I did a video on Seroquel quetiapine, which is a second-generation antipsychotic agent, mood stabilizer, that is being used a lot as a hypnotic agent, as a sleeping pill. And I talk about how that's maybe not the best idea. And I also did a video on Ambien recently. So I'm kind of focusing on sleep aids right now. And one of my viewers asked about Orexin receptor antagonists. And so here's a quick video on this class of medications. I didn't include it because I've never prescribed these medications. They've been out for a few years. 3 are FDA approved, and they're all brand name only still. Suvorexant, Belsomra, Lemborexant, Dayvigo, and Daridorexant, Quviviq. I think that's how you pronounce all those. At this point, they're still all brand name, and they're FDA approved for the treatment of insomnia, specifically problems with sleep onset and or sleep maintenance. So getting to sleep or staying asleep. They're classified as hypnotic agents, and specifically they are dual orexin receptor antagonists. Dual because there are 2 types of orexin receptors, and these medications block both. By the way, everything I'm going to say applies equally to all 3 of these medications. The differences are only in their potency, that is in the milligram strength, and the pharmacokinetics, their half-lives, so how long it takes the body to clear them. Otherwise, the pharmacodynamics are identical, and everything I'm going to say here applies to all 3 of these medications. Their mechanism of action is to block orexin. Now, orexin, which is also called hypocretin, it's got 2 names because it was discovered in 1998, almost simultaneously, by 2 independent groups of researchers. But orexin is an endogenous neuropeptide neurotransmitter, and it serves to stabilize and promote wakefulness. So when orexin binds to one of the 2 receptors, it promotes wakefulness, and it has some other actions as well, including stimulating the appetite. So these medications bind to orexin 1 and 2 receptors, blocking orexin from binding there and thus preventing it from promoting wakefulness. These agents are reversible inhibitors of orexin. So the action of these medications can theoretically be reversed as endogenous orexin is released upon awakening in the mornings, and even to a certain extent in the middle of the night. So this binding, this competitive binding, the medication will bind the receptor and block orexin, but it does so reversibly. So in other words, it detaches from the receptor, and orexin is able to get in and is able to stimulate that receptor and thus promote wakefulness. This is unlike the benzodiazepine hypnotics and the Z drugs, zolpidem, zaleplon, and esopiclone, which do not reverse upon awakening. And so if you take a lot, you can get a carryover effect. The other thing that's really unique, though, about this mechanism of action is that when you switch off alertness-related circuits, as opposed to switching on sleep-related circuits, this counters inappropriate wakefulness that might be associated with insomnia. Whereas these other sleeping pills that I mentioned and melatonin hypothetically induce sleep regardless of how awake you are. So I hope that's clear. When we're talking about the traditional medications that we have, the sleeping pills, and that would also include the barbiturates, it's actually promoting sleep by activating the sleep circuits, whereas this class of medication theoretically is working by blocking the stimulation of the wakefulness-promoting circuits. And so it's targeting a pathophysiology that is presumed to be you're too awake, you're wide awake for whatever reason. And there's different things that drive sleep and that drive wakefulness, orexin being one of them. Curbing alertness-related factors in patients with insomnia may have some theoretical efficacy and tolerability advantages over enhancing sleep drives, sedation, and somnolence. Orexin has other actions. It plays a role in appetite regulation. Orexis means appetite in Greek, and orexin stimulates the appetite, hence anorexia, no appetite, and this compound stimulates the appetite. It's to be taken no more than once per night and within 30 minutes of bedtime. This is good sleep hygiene. I've got a video on that about how you shouldn't take your sleeping pill way ahead of time. And you also shouldn't take these medications unless there are at least 7 hours remaining of sleep time. Taking these medications with or soon after a meal can delay the time to sleep onset, and so food does affect the absorption. Otherwise, generally, these medications take effect in less than an hour. Interestingly, it's not restricted to short-term use by the FDA. The FDA has approved these medications, but they haven't put the caveat that only 7 to 10 days, which is what you see with some of the other medications, such as Ambien. So one potential advantage compared to the other agents, if we want to stay on label, is to prescribe them for patients in whom chronic prescription is anticipated. The off-label chronic prescribing of insomnia medications is controversial, especially for agents that are habit-forming. These medications have been evaluated and found to be effective in trials up to 1 year with little or no suggestion of tolerance, dependence, or abuse. Are these medications habit-forming? Well, they're Schedule 4 drugs, so they are controlled substances. Schedule 4 out of 5 with the benzodiazepines. With the higher the number, the less controlled it is. And so these are among the lesser concerns as far as the ability for abuse and dependence. There was no evidence of physiological dependence or withdrawal symptoms with prolonged use in pre-marketing trials. Tapering is not necessary to discontinue these medications, and rebound insomnia does not appear to be a common phenomenon. Despite it being a controlled substance, it may even be safe to consider in patients with a past history of substance abuse who require treatment with a hypnotic agent, because we just haven't seen abuse and dependence in actual clinical trials. There's limited data as far as the safety of these medications in overdose. Sedation, of course, is seen. Obviously, no deaths have been reported. Notable side effects: sedation, if it carries over, can be a side effect. Headaches, dizziness, abnormal dreams, sleep paralysis, and hypnagogic hallucinations are possible. They are rare, but sleep paralysis is a phenomenon that's seen in narcolepsy, where a person wakes up but is unable to move. Narcolepsy is a disorder of REM sleep. And so you see some of the characteristics that you normally see when a person is in REM sleep, such as being paralyzed, only a person is conscious. Hypnagogic hallucinations and hypnopompic hallucinations are hallucinations that a person experiences as they're falling asleep or as they're waking up from sleep, respectively. And they're usually audiovisual hallucinations, but they can also be tactile. And you can even see dose-dependent symptoms similar to mild cataplexy, which is another feature of narcolepsy where you lose muscle tone. Again, this is very rare. One of the contraindications to using this class of medications is narcolepsy, because in those individuals, they already have a deficiency of orexin. In type 1 narcolepsy, there's destruction of the orexin receptor. It's an autoimmune condition in which there's a genetic aberration, and because of the genetic problem, so it's hereditary, a person develops an autoimmune condition where they destroy those neurons and they become insensitive to orexin, and they get these symptoms of sleep attacks during the day and possibly hypnagogic hallucinations, sleep paralysis, and cataplexy, where they lose muscular tone. a lot of times brought on by strong emotion. So they might get really mad and then kind of crumple to the ground because they lose muscular tone. Or somebody makes them laugh and they're just laughing and laughing uncontrollably, and that triggers a cataplectic attack. So that's the tetrad for narcolepsy. And if you have narcolepsy, type 1 narcolepsy, then you can't take these medications. It's just going to exacerbate those symptoms. Whereas you might see hypnopompic, hypnagogic hallucinations, sleep paralysis, and cataplexy very rarely as side effects of this medications. In patients with narcolepsy, you would be expected to exacerbate all 4 of those symptoms, which may already be present. Weight gain is unusual. It's been reported, but it's not expected. And you also want to, again, take these medications if you're planning to have a full night's sleep, at least 7 hours, to avoid memory problems with short-term memory. Some patients may exhibit abnormal thinking or behavioral changes. Anytime you give a psychotropic agent, you can have that, including uncommonly suicidal ideations. This is similar to what you might see with other CNS depressants. Depressant actions, in other words, causing depression or exacerbating depression, which might lead to the suicidality. This is very rare. It could also have disinhibiting actions, where a person's judgment may be impaired and they may do and say things that they would not otherwise have done were it not for the medication. This medication should only be taken at bedtime. It is a sleeping pill, and it's expected that you're going to be asleep while you're taking it. So you really shouldn't be talking to people or driving or taking any kind of action when you're under the influence. They should be used only with caution in patients with impaired respiratory function or obstructive sleep apnea. And the prescribing label contains a warning for the risk of next day impaired alertness and motor coordination. Complex sleep behaviors, including driving and eating, preparing food, making phone calls, that's been reported in patients taking sedative hypnotics. And so there's a caveat that if complex sleep behaviors occur, you should discontinue use. I don't know what the incidence is of that really. I think that that's just a general warning that we give to patients who are taking any sort of sleeping pill. Ambien and Halcyon are medications that are kind of notorious for that, for those behaviors. So I don't know that these medications are particularly notorious for it, but it is mentioned. There's a pretty strong drug-drug interaction with the cytochrome P450 liver enzyme 3A4, and so it's not recommended in patients that are taking inhibitors. If you inhibit that enzyme, then you can get toxicity. And then patients who are taking medications that induce that enzyme might experience reduced efficacy of these agents because you're inducing the enzyme that induces the metabolism of this drug. Safety and efficacy has not been established in children and adolescents, and controlled studies have not been conducted in pregnant women, but when administered during organogenesis in rats and rabbits, the no observed adverse effect levels for fetal toxicity were 25 and 28 times the maximum recommended human dose. So it's probably safe, but never recommended. All psychotropic agents are assumed to be secreted in breast milk as well, so it's recommended that you either discontinue the drug or you bottle feed if you are nursing a newborn. These medications are more expensive than some of the other agents, and so that's the main disadvantage. It's brand name only, and you might even have to get prior authorization before the insurance company will agree to pay for it. I have never prescribed these medications, so I cannot give you anecdotal reports of whether my patients did well or didn't do well. They would be anecdotal reports at any rate, but I'll tell you that the medications have not gotten great reviews. My colleagues tell me that they don't work very well, and I've had a couple of patients who were prescribed it by another practitioner who were not impressed. So that's probably why I didn't include it in my previous video. It's just not something I think to reach for. And maybe when they go generic and they're less expensive and easier to prescribe, I'll try them. But the advantage is that You can use them on label chronically and even in patients that may have chemical dependency. My guess, though, is that they're going to come back, and especially those patients, and they're going to tell you it's not working. But if any of you out there have been prescribed these medications, please comment. Please leave a comment in the comments section. Even though, again, reports are anecdotal, I want to emphasize that when you guys read stuff, someone else's experience is their experience. It may have absolutely zero applicability to you. However, please do share your experiences and your opinions. I think it would be helpful for patients to see what other people have experienced, as long as you know that it's not necessarily going to be the same in your case. Thank you for listening. Comments are always welcome.